Welcome everyone to the CSSE webinar, Beyond Impairment, Managing Safety Risks for Cannabis. We're pleased to offer you this topical webinar that will give you the tools to manage an evolving category of risk. My name is Erin Crisfield. I'm CSSE's lifelong learning consultant, and I'm your host for today. For those of you new to GoToWebinar, I'm going to give you a very quick introduction to what's on your screen before we begin. On the right side of your screen is the GoToWebinar doc. There are 3 icons with drop-down arrows there. The first is your audio, which will show that you're muted for the webinar, and I'll let you know how to participate in just a moment. The other area I'd like to draw to your attention is the handouts with the page icon. There you will find the handout, and you can download that now. The handout has key points and space to take notes, so it'd be useful to have open during the webinar. We'll also provide you a link with the recording and the handout tomorrow after the webinar so that you have access to those offline too. An area called Questions Chat with the hand icon. This is how you can participate in the webinar. So if you have any questions during the webinar, please type them into that window. I'll monitor all questions related to the webinar content, and we'll have a time for questions at the end of the webinar. And if you have any technical questions, you can type those in there as well. We'll also have a question for you during the webinar and a couple polls, so there'll be chances for you to interact, and you can type your responses to the questions that we ask you in that chat area. And now to introduce you to our presenter for today. Nadine Wentzell is a pharmacist who helps employers mitigate the workplace risks of substance use. She routinely provides guidance on best practices in policy development and implementation, including the complexities of testing. Nadine's boots on the ground experience means she knows the issues and how to address them effectively. So Nadine, over to you.
Thanks, Erin, and to all the people at CSSE for the opportunity to present to you today, and for all of you who are attending and those who may be listening later. Okay, so as a pharmacist, I'm required to identify if I have any conflicts of interest. So here's my disclosure. I have no relationship or commercial interest with any pharmaceutical or cannabis company, product, industry affiliation, nor endorsement. And what I'm coming to realize is that's very unusual. Many people who speak on this topic are overtly or covertly funded by the cannabis industry. So if you're listening to someone, I encourage you to find out who is paying them. The only not-for-profit organization of relevance is the Canadian Consortium for the Investigation of Cannabinoids, which sort of sounds like a drug cartel, but what it really is a group of pharmacists and doctors who are collaboratively looking at best practices, sharing research information and ideas. And it's great for me because when I have questions that are very technical, I have a huge resource base to go to. And then finally, I'm self-employed as a consultant. As Erin said, this is the work I do. The only commercial affiliation I have in that regard is with LifeMark. They're a disability case management company, and I have the opportunity and the pleasure to work with them and some of their high-level occupational medicine doctors and other professionals. So it's been great. All right, so we're going to look at our objectives, and I want to emphasize that at the beginning, I'm going to spend a bit of time on the science because I want to balance that and give you a lot of practical information, but it's important that you have some of the key pieces of science for reference because what I'm going to be talking to you about is where many people have questions. So if nothing else, you'll have this as a resource, and you can always follow up with me later if there's something that's not clear or you want in more detail. But when we're thinking about this, these are the 3 things that Erin and I came up with. We want to identify or help you identify the difference between impairment and safety risk, and this is really important. I want you to be familiar with several practical tools that help identify those safety risks, specifically to cannabis, but generally they are transferable to any substance abuse. And then finally, how do we get our employees, to take action under the internal responsibility system, that's implied or very clearly stated in some versus other provincial health and safety legislation. So those are the 3 key pieces we want to focus on and give you some tools to be able to move forward with. Alrighty. So looking at why are we doing this, workplace health and safety goals, what we really want to do is foster culture change. Most people have a very punitive approach to drugs and alcohol and substance abuse and addiction. We all have had usually some sort of experience and it's never positive. So it's changing that mindset and helping people understand that we are not about identifying bad people who are using illegal drugs and firing them. That's a very punitive approach. It's an American approach, and it's very alive and well and living there. We in Canada approach it much differently, and I have a lot of colleagues in the U.S., and I firmly believe that we have better uptake and better healthy work environments because of this approach. So we're looking at, of course, the health and safety of employees, but also the work environment. That second part sometimes gets missed. And we want to foster that culture of care and support because people with addictions, addiction is an illness identified by specialists. It's a brain disease. I could spend a lot of time talking about that, but we have lots of science to prove that. That's often a stumbling block for most people. So that's part of it. We want to also make sure that anyone who is identified or has any connection to substance abuse in the workplace, that everyone is dealt with consistently, that there's not different standards depending on who you are, and that's one of the things people often tell me as well, and obviously respect for people. And what my clients tell me most is I enable employees, I get them to listen, I'm able to engage them, and so what happens is that results in culture change. And that's what we want to happen, because the ultimate result is we have decreased incidences and increased productivity. And actually, one of my clients has recently very clearly stated that they believe that their 80% drop in workers' comp premiums is directly due to the drug and alcohol policy we put in place. So that's a pretty sounding endorsement there for beginning this process. And, little steps. We start wherever we are and we go from there. So we want to really focus on employees. We want to engage them in a way that helps them understand that this is for them and for their benefit. Okay, so let's talk a little bit about cannabis specifically under that whole umbrella of health and safety. What is cannabis? You may hear your people talking about sativa or indica. Depends on what the context is and where you are. And the reason I mention this is so that you'll have some level of familiarity if you don't already. The sativa part is the part of the cannabis or the strain that tends to be more excitatory, more stimulating, and the indica more sedating. Well, that's what we used to believe, but there's been so much hybridization that I don't know if that really holds true anymore, but it's certainly a strong belief out there in the population that use cannabis. We do know that it's been around for thousands of years recreationally and medically, and we also know that there's over 110 active compounds. So let's think about that. We are familiar primarily with THC, the psychoactive part, the tetrahydrocannabinol, and CBD, which is the non-psychoactive part. So that means there's another 108 active chemicals that are going along that we really don't have a whole lot of information about. Okay, so big picture-wise, what are we talking about? We know that in our bodies we have at least 2 circulating cannabinoids on a regular basis in minute quantities. We have already cannabinoid receptors in our brain and other parts of our body, and those are the receptors that these 2 internal chemicals would stimulate. When we introduce herbal plant products like THC and CBD, it's like feeding us with a fire hose. Those poor receptors become overloaded, and then we have a lot of adverse effects. And then the other products that we have available are the synthetic ones. These are the prescription products that are approved in Canada by Health Canada or in the U.S. by the Food and Drug Administration. They are patent medicines. They're prescription products. There's a specific chemical that's been researched for 20 years, and it's been approved for a particular use. So in Canada, those 2 are Sesamet. It's been around for over 30 years, primarily to treat chemotherapy-induced nausea and vomiting, and Sativex, which is a combination of THC and CBD as plant extracts. So those are the 2 that are available on the market in the U.S. In Canada, sorry. The others are in the U.S. and not in Canada, but you may hear people mention them, which is why I provided them here. Okay, so this is a pretty encompassing slide, and the only reason I show it to you is because people tell me that they find this very fascinating and interesting and helpful. So what we know is that cannabis affects at least 8 different parts of our brain. And I'm going to focus a fair bit of what I talk about on the neocortex, but you can read all the different areas, the parts of our brain, the neocortex, the prefrontal cortex that's responsible for those higher cognitive functions and integrating sensory information, the hippocampus for facts and sequences and places, and then the cerebellum. I'm going down the right side there, the Center for Motor Control and Coordination. So all of these areas, in addition to the 5 on the other side, are affected in a negative way by cannabis. You might find it interesting to know that alcohol also affects these areas of the brain and other parts. So 1 and 1, and many people combine cannabis and alcohol, is not 2. You get a greater enhanced effect, so it's more like 3, 4, or 5. Okay, so that's a quick overview on marijuana's effects on the brain. Now let's get into the medical cannabis. This is an area where there are many questions, there's a lot of confusion, and very little factual or clearly understood information. And the misconception is if I have a card for medical cannabis, then I can use it wherever I want, whenever I want. And employers are uninformed and they don't know what to do, which translates down to how do you as supervisors know what the heck to do? Okay, so I want to tell you a little bit about herbal cannabis first. For medicinal purposes, it is authorized, not prescribed. And any of you who know me know that I get particularly cranked about this, probably because I'm a pharmacist. But the cannabis industry uses the word prescribed to confuse people and to try and legitimize their product. It is not a patent medicine. We don't have a specific chemical for a specific treatment. The two groups of health professionals that can authorize it are nurses, nurse practitioners in certain provinces, and physicians in any province. You may find it interesting to note that there is no required additional education for the authorization of cannabis. It's regulated by Health Canada under the Cannabis Act, and until 2016, people with medical licenses could only purchase through licensed producers that were approved by Health Canada. In 2016, the Supreme Court expanded that to say that individuals could grow their own or they could designate someone else. So what often happens is you'll get someone contacting a licensed producer for their first purchase, and then they usually go on and purchase from personal producers or grow their own or both. And the interesting part is when even the medical authorization is in play and the individual contacts the licensed producer, the person on the other end of the phone is not a healthcare practitioner, they're a salesperson attempting to instill brand loyalty for a particular product and repeat sales. So it's a very commercial enterprise, and the only place where the physician or the nurse practitioner gets involved is at the beginning, and usually it's just related to quantity. Very rarely is there ever a percentage of THC or CBD. So it's the Wild West. We just don't know. We do know that there's, as of last week, over 360,000 medical authorizations. They continue to increase despite legalization. And from a monitoring perspective, there is no oversight. No one checks with any of the physician's authorizations or the nurse practitioners, only if employers ask questions. So really, it's free reign. And there's a lot of untoward practices going on, a lot of money exchanging hands, and I'll talk a little bit more about that as we go forward. So the key fact is that there's not a lot of control over the medical cannabis. So what do doctors do? Well, the College of Physicians and Surgeons, the College of Family Physicians of Canada in February of 2018 provided a guideline document for all health practitioners, in this case, physicians and nurse practitioners, who were looking at authorizing cannabinoids or prescribing cannabinoids, if we're talking about the prescription products, to give guidance to people because there was nothing there. So I think, Erin, we have a discussion question here. Would that be right?
We do. So a question for participants here, and you can type your answers into the chat or the question window there. And the question is, what is medical cannabis used to treat? So type your responses in and I'll read them out because Nadine can't see those, and I want to make sure everybody hears all of the answers that are out there. What is medical cannabis used to treat? Type that into your window there, their chat window. I'm watching for some responses to come in.
Okay. Like suspense here, because you're right, I can't see anything.
There we go. So we got cancer. I'm just going to make my window a little bit bigger here, see if that helps. So what have we got? Cancer, anxiety. Responses from Betty and John. Reese says PTSD. Heather says MS nausea. Any other thoughts, folks? What's medical cannabis used to treat? There's three big ones there for you, Nadine. Oh,
yeah.
Anxiety, okay. Muscle pain, a few saying anxiety.
Okay.
Thanks, everybody.
Hey, thank you. That's really helpful to know. Okay, so these group of specialists, clinicians from the University of Alberta and UBC, and I know some of them, and they're very top-notch researchers. They reviewed over 1,000 articles internationally. So they looked all over the world to see what's the research, what's the evidence tell us. And they came up with this prescribing algorithm for physicians and nurse practitioners. So it's a busy slide, the next one that you're going to see here, but it really helps, I think, encapsulate the whole process in one picture. So Erin, can I get you to advance to the next slide there?
There you go.
There we go. Okay, here we go. So what they said was, if you're considering medical cannabinoids, first of all, is it for neuropathic, which means nerve pain, palliative pain, and end of care pain, spasticity in multiple sclerosis, so that's nerves, the tremoring, muscle tremoring, in multiple sclerosis or spinal cord injury, or nausea and vomiting that's secondary to chemo. So if the person who's considering cannabinoids can't say yes, then it's recommended against. if they can, generally, in my experience, people who fall into this category, they're too sick to be working. But let's put that aside and go down to the next one here. So if you can say yes to that first group, then if it's for nerve pain, it's expected that the health professional would have tried 3 or more medications for reasonable periods of time that are recognized to treat nerve pain and proven them to be ineffective. If it's for palliative pain, it's 2. Or if it's for chemotherapy, induced nausea and vomiting, or that spasticity second to MS or spinal cord injury, then all the other standard therapies that would normally be used have been tried for a fair bit of time, reasonable trial periods, and proven to be unsuccessful. If you can't say yes, then again, recommended against the use. If you can say yes to the second line here, then we go down to, they may consider the medical cannabinoids as an adjunctive therapy. That doesn't mean first line, that means third, fourth line therapy in conjunction with other treatments, and then they are only recommending one of the 2 prescription products. So what this tells us is that there is no evidence at this point in time to use herbal cannabis for any of the things that you've identified. A lot of people have a hard time accepting that, and the cannabis industry has done a very good job of lobbying and providing information that is not supported by the evidence. So what does that mean? So where do we go? Well, where do we stand with all this? Well, from a Health Canada perspective, they don't recognize marijuana as a therapeutic drug. They were required by the Supreme Court to allow medical authorization to have some process, but they do not recognize it because it's not a patent medicine and there's no evidence. It cannot be prescribed. It doesn't have a drug identification number, which any drug that's gone through the 20 years of research and development and clinical trials and chemical isolations and risk versus benefit analysis, once that's approved or once that's all been sufficed, and the scientists at Health Canada have agreed that they have all the evidence they need and they're supporting licensing it as a prescription, then it's given a drug identification number. And that's what's used when we receive prescriptions with any of us who have medical plans. When that's sent through by our pharmacist to the health insurer, they know by the DIN number that it's a licensed product in Canada, and there is no notice of compliance. So going back to, again, there is no evidence to support this. Okay, so that's all the medical stuff. What about legalization? Well, in the fall of last year, last October, we had cannabis legalized. We are only the 2nd country in the world to legalize cannabis. Many have decriminalized it, but Uruguay is the only other one that's legalized it. So what does that mean? Okay, so who can purchase it? Any person over the age of 19. The recreational cannabis use in Canada, I'm going to get you, thank you, Erin. Any person over 19, and what products can people buy? Well, dried flower, most people know that. Oils, pre-rolls, so pre-rolled joints, capsules, seeds available only online, and edibles, even though we're at the stage where it's licensed, there's a regulatory component to allow them to be sold. There's an approval process that is yet to be completed, which means we probably won't see them on the market until later in December or maybe even longer than that. However, for recreational use only, so it's important to remember that the legalized stuff that we're getting provincially is only for recreational use. And some of my friends who work in some of these commercial establishments tell me that every single day they get all kinds of requests for medical use, and they then send them back to the licensed producer, and so that the individual has their authorization, and that's how Health Canada monitors that the authorizations are legitimate, that the licensed producers have that in place, if that's where the product is being purchased. Okay, so now what? I couldn't resist this slide with the prominent buildings in the background and this guy with a marijuana leaf on his toque there. People think because it's legal, they can use it wherever they want, wherever they want. And whenever they want. So in this way, it is like alcohol. You can't drink before work or at work, and similarly, you can't drink or you can't smoke up or smoke during work or before work. So the whole part about the fitness for work is still there. Nothing's changed, and poor performance and behavior will be disciplined. So from a supervisor perspective, what safeguards are you putting in place? What's the information that you're going to provide to employees so that they understand that? Because there is rampant misinformation, and people think really it's very much more permissive than what it is. So my goal from here forward is to give you some more information to help you educate your people on that. So Erin, I think we have a polling question for the next slide.
We do. I'm going to launch the poll for you.
Okay.
So you should see that on your screen, everyone. The question is in the 60s, 70s, 80s, what percentage of cannabis? And you've got some choices there. You can click the one that you want to vote for, and we'll see how many of you get that one. So we've got a few votes coming in. Excellent. Get your clicker fingers going there. About half of you have voted. I'm going to give you a couple more minutes to select one of those. It's completely anonymous. Doesn't matter if you get it wrong. 2/3 voted. A couple more seconds. All right. Looks like that's everybody who's going to vote. So I'll close that and share the screen with you there. The responses. 25% said 10%, 25% 18% said 15%, 44 said 2 to 3%, and 6 said 95%.
Well, we have some informed participants here because 2 to 3% is the right percentage. So when you think about that compared to what we have now, and we'll move on to the next slide there, Erin, we have the opposite extreme. So I couldn't resist the Cheech and Chong slide there. But we have products that are available, and the names that are given on the street are butter, that's a play on words, of course, and shatter. The reason it's called shatter is because it's kind of like toffee. When you hit it, it breaks like glass. Those products are 60 to 95% THC. And I know for a fact that there are kids in high schools using the shatter in vapes that they have with them at school. The butter is more so what you're going to find used in edibles, but these products are very readily available. About 6 months ago, I was doing a workshop with supervisors in a relatively isolated part of one of our Atlantic provinces, and they are telling me how to make shatter and butter. That's how common it is. So we don't know because the percentages are all over the place, and unless we have a retail purchase product which has the percentage of THC or CBD or something from a licensed producer, there's no clue what the concentrations are in the products. And even for products that are marketed as primarily CBD or pure CBD, they're not, because you can't physically separate THC from CBD, not at this point in time. So there may be lower than 1% THC, but there's still THC there. And then the other extreme is up to 95%. So it's a huge problem because we just don't know what people are consuming. So why are we concerned? Well, Health Canada has identified a number of things, and I know most of you probably are familiar with much, if not all of this. So I want you to think about these impacts from the perspective of cannabis affects our brain. And you probably are at least somewhat familiar with some of the information that was circulated around the legalization last year and the age of consent or the age of purchase. We know that the brain does not completely develop until age 25 and now up to age 28, more recent research. And we also know that the age of onset of use in Nova Scotia is age 12, and in BC it's 9. So what does that mean for the developing brain? We know that cannabis affects it in a very negative way, the neuroplasticity. I'll ask you to go back for just a sec, Erin, to this previous, no, the other way. There we go. Yeah, the neuroplasticity, if someone stops using, does that eliminate itself, and does the brain normalize and form normal functions and normal connections between neurons? We don't know because we haven't studied it yet. There's someone at Dal, a toxicologist, that's part of her research project, but we just don't know. But the reason I'm mentioning this is because what does that mean for our emerging workforce demographic? A couple other things that are important around reaction time and coordination, specifically safety-sensitive positions, ability to think and make good decisions. I love it when my friends who smoke pot tell me that they're safer driving after they've had a joint because they're slower and they're more cautious. Well, that kind of eliminates the fact that they reaction time and their coordination shot, and generally their motor skills too. We know that cannabis increases anxiety and panic attacks, so why would you give someone that's experiencing that cannabis? We also know that in up to 25% of the population, it can cause paranoia and hallucinations and trigger underlying mental health disorders. And particularly in young males under the age of 25. And I can't tell you the heartbreaking stories I've heard from many people at my workshops who have had experience with this firsthand. It's heartbreaking because once that happens, it's not reversible. We also know that it's physically and psychologically dependent. We become dependent on it, and a lot of people don't acknowledge or accept this. Part of the reason is, I think, the parts of our brain that we need to determine whether or not we're impaired or unsafe or addicted are the parts of our brain that are affected on a long-term basis by cannabis. So it's like a catch-22. And then there's some others. The other one that's often a big concern, I mean, not that any of the rest of these aren't, but the decrease of impulse control. So people are much more apt to engage in risky behavior. So your body doesn't care, regardless if it's recreational or medical. Cannabis is cannabis, and it affects your body the same way. So how do we figure this all out? Well, with regard to the acute impairment, and I'm using that term here because that's what you will see in the literature, we are relatively reasonably confidently able to have that for qualifiers, able to determine impairment when we have that acute intoxication. Most of us know what that looks like. You smoke a joint, you get high, you stay that way for 3 or 4 hours, and then that drops off quite quickly after that time. That's pretty easy. What's much more difficult to discern is the chronic use. So people who are using cannabis on a regular basis, if they're using higher concentrations and using a lot of it, then they're going to have those fat cells in the brain saturated as well as all other parts of our body, which it can take weeks for that to be eliminated. So they're going to have a circulating level, which would make them unsafe. And this is the part that many, many people don't understand, because that circulating level affects all of these things that are identified here, our ability to learn and concentrate. It impacts what we hear and what we see and our time. It's all distorted. So that's the part that's most difficult. But we're not looking at impairment from, again, a punitive perspective. We're looking for safety risks. So that's why you've seen that I've highlighted those in both those situations. And this is the part that is very important to make sure, I think, all of your employees are aware of. You know, from an impairment perspective, the only measure we have is in blood, and that's from an enforcement perspective related to driving. We're not police. We're safety people. And so our job is to look out for safety. And when I say to someone, you know, when I'm doing supervisor training, I'll say, you know, this thing about determining impairment, and you can just see people recoil because they feel so uncomfortable and so unqualified. And when you say, well, how about safety risk? Well, then you can begin to see people get engaged. And I've asked occupational medicine doctors, leading ones across this country, how they determine impairment, and they say they can't. I've been doing this work a long time, specifically with cannabis. They say they can't. And I'd say the same thing. I'm a pharmacist. I know what drug addiction looks like, but I couldn't determine impairment. So that is left to the purview of the toxicologists, and we have a few in this country. But we are much more equipped to look at safety risk. That's a much easier task. So some of the complicating factors, I've already talked about how cannabis and all of its chemicals that are in it are fat soluble and they stick around in our body. Urine testing is the one that's most common, and we don't have levels that equate with impairment. If anyone asks you that, they're metabolites, so all we know is that someone's used a substance in the past. Oral fluid levels are much more aligned with recent use, and so in reasonable cause and post-incident situations, oral fluid levels are most common in any employer that's had a review of their drug and alcohol policy within the last year or two. And then there's always the question about, well, lab analysis versus point of collection. What do we need? Point of collection are those quick tests, or the ones you get with an answer within, or result within 2 to 5 minutes or 5 to 10 minutes. Only really, I recommend using them only in emergency situations where you need to know if you need to stand someone down in an isolated environment. I don't believe any employer should ever take any action without lab-based analysis, and we only have one in Canada that's qualified and certified to do that type of analysis. So these are some of the things that complicate it. Most employers don't understand testing, and it goes south in a hurry, and that's why we have arbitrations. So I'm going to say a little bit more about testing in a little bit, but those are some of the additional pieces you need to be aware of. Okay. So we want to look at this from a safety perspective, but always it's about finding that balance. The fitness for duty is the key piece. So that's the foundational piece, and we're looking at safety. And then we also have to look at labor agreements. We don't want to be in conflict with those. Privacy, it's critical that privacy be maintained, and human rights. We don't want to discriminate against anyone who has an addiction. And most employers don't understand that component of human rights. And it's a very valid one and a very important one. Okay, so continuing on, so what about safety at work? How do you know? As a supervisor, how do you know if someone's high, or what's that safe time frame, and what are the guidelines? Okay, so there's some guidance from a few sources. There are others, but these are 2 or 3 that I want to share with you that are really, I think, most relevant. So the first one comes to us from the World Health Organization. They commissioned a study with Harvard and they looked at off-time work use. So people always say, and we'we'll go to the next slide, Erin, people always say, what I do in my own time in my own business is my own business, and I say, sure, as long as that doesn't ripple over and, in fact, affect your ability to be safe at work. So what these people at Harvard found was that complex human/machine performance can be impaired as long as 24 hours. There's a 24-hour limit after smoking a moderate dose of cannabis, and the user may be unaware of the drug's influence, going back to those parts of the brain that it affects. So they went on to say in the same study that recently abstinent cannabis users, so we'll go to the next slide, please, Erin. Recently abstinent cannabis users, so people who stopped between 7 hours and 20 days, may experience impairment in attention, concentration, inhibition, and impulsivity during the period in which the THC and its metabolites are eliminated. Because what most people don't know is some of the metabolites are also psychoactive. And then finally, the last statement here, the greatest residual deficits are in those executive function and are found after prolonged use of cannabis. Well, that just makes sense. The more you use over a longer period of time, then yes, those effects are going to be more latent and more residual. But what do we mean by executive function exactly? So that's what we have on the next slide, where there's skills really that allow us to take stock of a situation, to assess what are the options, what's the best one, and then how do I do that? So those are the skills that we need around attention and concentration, reaction time, risk-taking, and impulsivity, and our working memory. All those are adversely affected by cannabis, and most people don't recognize this. Okay, so in addition to that study, we have the Occupational and Environmental Medical Association of Canada. They came out with a whole position on what about safety-sensitive use in cannabis. So the statement that's most relevant there is the one that's on the next slide. It's statement number 2. I encourage you to access this because it's a short document. It's only 2 or 3 pages, and it's a really quick read. But the one that's specifically relevant to what we're talking about right now is it's not advisable to operate motor vehicles or equipment or engage in other safety-sensitive tasks for 24 hours following cannabis consumption or longer if impairment persists. So there's that 24-hour window, which gives us some confidence. And if, depending on what you look at, if you look at pilots, there's a non-use at all, there's an abstinence. If you look at the Canadian Forces, depending on the engagement of the activity, they have different time frames, but 24 hours is certainly a window that many employers use. I don't recommend it because if you're using those higher concentrations, 24 hours isn't going to come close to being a reasonable amount of time for which people can be safe. Okay, so what resources are available in addition to those two for reference from an employer perspective, from a health and safety perspective? Well, we all know about the Health and Safety Acts, where the employer's obligation is there to provide a safe workplace, and employees are expected to be responsible for their own safety and the safety of others. What people sometimes forget or maybe aren't aware of is the criminal code offense that was added as a result of Westray. So I've got a little picture of the memorial for Westray on this, and of course, on the next slide, it's near and dear to my heart because it happened in Nova Scotia, hard to believe, 2004. The criminal code was amended to identify, and I think it bears reading through this to keep it top of mind. Everyone who undertakes or has the authority to direct how another person does work or performs a task is under a legal duty to take reasonable steps to prevent bodily harm to that person or any other person arising from that work or task. So that's where the Metron case came in, and people were successfully fined hundreds of thousands of dollars, and there was even jail time assigned to one of the individuals in that case. That's the only one I know of, but that's a pretty heavy piece for people to be aware of because that is the extreme of what can happen when there's negligence where safety was completely not even considered. Okay, so in addition to all of that, there's employer law obligations around human rights, and I've referenced or alluded to this a little bit earlier. Addiction is an illness, it's a disability under federal human rights, and so an employer cannot discriminate against an individual, and they have a duty to accommodate. And what does that mean? I'll talk a little bit more about that in a bit. So, then not to be negated here is the responsibility of the employee. Sometimes that's not really emphasized. And so this is another area where I would encourage you, if you're not already, I'm sure many of you, if not all of you are, but to reinforce that fitness for duty requirement, especially with cannabis use that they're doing on the weekend or maybe when they're not at work, that can affect their time at work. And then again, their responsibility for their own and others' safety. the expectation that they apply training and education. So if you provide them with some of this information that I'm giving to you in little small bites and whatever works for you, they can't say they didn't know. And of course, the important piece there is to document what you've discussed and sort of what the overview has been. And then cooperating with employers, and that's usually in the context of a policy. And then we have that internal responsibility system. So I'm going to spend a little bit of time talking about that. And of course, on the next slide, I'm quoting Dr. Peter Stralendorf, our guru here around IRS, and he very succinctly says, everyone at all levels takes the initiative on health and safety. As well, everyone is obligated to report unresolved concerns upward and to respond properly to the unresolved concerns of others. So it doesn't matter where you are within the organization, everyone has that responsibility, frontline all the way up to and including the board of directors, and I've got a slide on that in a minute. But what Dr. Stralendorf identifies, and I think is so important to remember, is we're basing this on core values of life and health. So it goes back to the beginning of what I was saying, of focusing on health and safety, not bad people who do bad things and we want to get rid of them. And making sure that people personalize this, because if someone has a problem with addiction or substance use in the workplace, the first people that know are their coworkers. So creating that openness and a process where people know that if they can get help, if they want to get help, they can, so that there's a responsible accountability and help from the company. And then the openness around this and to make sure that it's always approached from a problem-solving perspective. How do we deal with this? And at the end of the day, we're responsible for each other. We are our brother's keepers, and many times people's best friends are the people they work with. So just to emphasize some of that in relation to values hopefully helps a bit with that IRS, to keep it front and center, because as I said, I can't tell you the number of times I mention that and people look at me like I have two heads. So even though we assume people know it, I don't think that that's the case. That's certainly not been borne out from my experience. Okay, so on the next slide, we have something very colorful that I would try to be creative with, and I hope it doesn't make you dizzy. It's an attempt to visualize in a little bit different way. And again, this is taken from Dr. Stralendorf's work on his basic structures around authority, responsibility, and accountability. So to show on the right side that the accountability goes upward, starts with the people on the ground floor, the frontline staff, the people doing the hard work every day, your workers and your employees, and it goes all the way up to the board of directors. President and GM, obviously operationally, and depending on the activity of your board, some are more operational than others, but there's ultimate responsibility there. And then the other side of that, so the accountability all the way up, and then the responsibility and the authority delegated all the way down, so that within an organization, there should be a perception and an understanding that there's a responsibility and there's also authority to support that, so that people, if they're brave and they do take action, that then they're supported in that. And again, how you choose to do that within your organization is something that I would encourage you to think about. If you haven't emphasized it already, what are some ways that you can begin to help your people understand this and really drive it home that it's everyone's responsibility? Okay, so a little bit wordy slide, the next one, and my visual here was to show that there's multiple people involved. Again, the primary purpose of all of the occupational health and safety legislation provincially is to facilitate a strong IRS in the workplace. So we're identifying those specific duties of employers, supervisors, workers, contractors are sometimes forgotten, owners and suppliers, they're all under that umbrella because they all have a compliance with the respective statutory duties. There's a requirement there, it's essential. And making sure that everyone understands that they have a role to play, that no one is immune, no one gets a buy on this, it's everyone's responsibility. And again, that there's a statutory duty to report so that people understand what happens if they don't. And this is not about threatening people. It's about helping people understand that there's an accountability and there's consequences if those accountabilities aren't met. So if you don't act and it's been able to be proven that you knew, then there's a problem that needs to be followed up. Okay, so how do we translate this into the workplace? Employers and supervisors, of course, are a bit redundant here, required to address identified situations and ensure the workers are aware of any hazards in the work they do. More importantly, or equally importantly, I guess I should say, is to support a safe and healthy workplace. Well, how do you do that? You have well-defined safety policies and programs. So you've got processes and you've got policies. So moving right along. This is where we combine the health and safety in the IRS. We have a strong policy. So what are some key elements? Well, you're probably getting a little tired of me harping on this, but you focus on safety risk. Empower your supervisors to do what they know how to do and what they're comfortable doing. Do not talk about impairment. We are not work police. Clear expectations, reference your policy, your work rules or your work standards. Where are the lines? What's the expectation around fitness for duty, and what happens if I don't follow that? Work collaboratively with unions. I have worked with a lot of unions over many years, and I have yet to have any single one of them argue that health and safety is a bad thing. And if you are truly walking this walk, they will buy in without question. I've never had resistance there. But you have to be sincere and transparent about all of this, because there's a lot of paranoia and misunderstanding around drugs and alcohol, especially policies and testing. So you can't be transparent enough from my perspective. I've already talked a little bit about the discriminatory language and processes. So, talking about catching people or punishing people, or I read one policy that said something about you will obey, and I'm thinking, oh my dear. And avoid the words zero tolerance. Now, I know some of you probably have that in your policies. I strongly recommend against it, because what you mean and what people hear are probably two different things. You want to have a safe work environment that doesn't have drugs and alcohol in it, but what they hear is, oh my goodness, or probably something a little stronger. If I mess up, I'm toast. I'm out of here. One screw up and my butt's out the door. So that's what zero tolerance means. It means that we've got no tolerance. You make any mistake, you're gone. But what you really want to say is a drug and alcohol-free environment. So it's not being pansy-ass with the language. Sorry, it's not being it's not being what's the word, weaselly with the language. It's really about saying what you mean, so that there's minimal opportunity for misunderstanding. Of course, privacy is critical, especially in this context, because of the personal nature of some of what will be coming forward, especially related to testing and perhaps individual situations and circumstances. So privacy at every level is expected. And you, again, think about how you apply that, how people know that, what you put in place, and the confidentiality. Okay, at all levels. So how do you translate this into action? You're probably still asking me when you get to what we need to do here. So how do I know what to say, what to do, or how do I know? How do I know what's going on? So Erin, I think we have a discussion question here.
We do. So again, folks, you can type your answers into the chat window. And the question is, what resources are currently available in your workplace or elsewhere to support you in addressing cannabis, excuse me, and other substance use that affects safety? So what resources do you have available, whether it's in your workplace or somewhere else, to help you address cannabis and other substance use as it relates to safety in your workplace? You type your answers in there and I will read them out so that everybody hears them all. What resources are you aware of? Consultants. It says consultants.
What was that first one, Erin?
Reese says consultants.
Okay.
Other resources you have in your workplace or you have access elsewhere: medical professionals, fit for duty guidelines from Safety Association, that's from Terry. Angela says we have addiction services accessible through our benefits program. Anyone else have resources to add to that you're aware of, your workplace or elsewhere you can get access to resources? Well, that's what we've got for now. If anybody else adds in, I will let you know.
Okay, that's great. Thank you, everybody, for that information. It's helpful. So initially, when I asked this question, I was thinking about, or I wanted to focus on, what are some of the program resources that you already have in place? So going to the next slide there, Erin, doing toolbox talks. And I think most of you, maybe not all of you, but many of you do toolbox talks or have safety talks or whatever term you want to use. If you have a policy, begin to, I would suggest, introduce that. Just in little snippets, choose one piece that you want to talk about so that it becomes normalized, people aren't afraid of it, and they become familiar with it. So that's a perfect opportunity. And you might want to start around the fitness for duty, or really, there's no right way to do this, just start it. Getting started is the most important part. And if you're comfortable, I've given you some resources today, and I can certainly provide more as a supplement to this webinar, but educate people on substances, specifically cannabis, and how it differs from alcohol. You know, alcohol is easy. It's in and out of our body within a reasonable period of time. We eliminate a drink an hour. A drink is 10 ounces of beer, 5 ounces of wine, or 1.5 ounces of hard liquor. So you can do the math on how much you consume and how quickly it leaves your body. With cannabis, you can't. There's no process, there's no formula that we have. So helping people understand that it's not as safe as most people realize, and it does have longer term effects around safety, is a really important piece. And if you're going to do testing, when, how, and why, and I'll talk about that in a further slide in a little bit more, but when are you going to do testing? People need to know, and they want to know. They want to know how the testing is going to be done and why you're going to do it. So have those discussions. So first of all, make sure you know yourself, and then have those discussions again, be open and transparent, and encourage them to ask questions. And another one I didn't put here is you might want to even assign different people at different weeks the responsibility to have the toolbox talk around substance use. Maybe you want to do it once a month. I don't know, whatever works for you, but make it normal, make it part of your routine, and then it's not this big ugly elephant in the room that no one wants to talk about. Okay, and checking in. So at the beginning of the shift or at the end of the shift, check in with your people in close proximity so you can see what they look like. You can smell anything that may be off. And also ongoing, because some people may use during the shift, and so they may know that you're going to check in at the beginning, at the end. So do it during their shift as well. Now, I know a lot of supervisors have a lot of responsibilities, and they're not always in close proximity. So this may not be practical every day, but begin to integrate it into what you do, and it will certainly help. And note what you see. So be observant. The most important thing you can do is know your people. Know what's normal, whatever that is, for them, and then know what is out of character, and note that when you see it. So again, base it on what you're seeing that's differentiating from what you would normally see, those check-ins. And reports from others, so important. I can't tell you the number of times that information come to supervisors and managers from clients or from coworkers and contractors. So you want to do internally, foster a culture where people feel comfortable reporting, so they're not going to be perceived as ratting someone out, and you have to put the right processes in place around confidentiality and who reports what to who, but also clients from an external perspective and contractors. Help them understand that you want a drug and alcohol-free environment. So again, it's about being transparent and creating that openness. So the next page are some more policy-related resources that hopefully, if you have a policy, you have an observational checklist that identifies speech and walk and smell and all of these things that you would see that could lead you to believe that there was a substance involved. And again, facts, not assumptions. So if your gut's telling you that something's off, it probably is, but gut feelings are not facts. So note what's there, have a checklist, and have an option to record other things that may not be there. And then always compare, review with a second supervisor or manager in confidence with what you're seeing. So it's like that second check, that sober second thought. And that hopefully removes bias, and it also helps other people recognize that there's a problem and you can problem solve together on how to move forward. So if you're going to test, be aware of, first of all, what drugs, and have a discussion around this. So many employers allow their TPA, their testing party, their testing company to tell them what to do. But really, you're driving the bus, you're paying them for a service. So what drugs do you want to test for? And there's a lot of employers that don't test for the panel that they could, and sometimes they're testing for drugs that are not even on the market anymore, and they're paying for things that that they don't need to be paying for. So make informed decisions around that. And what specimen type? I've alluded a little bit earlier that if you're doing reasonable cause testing or post-incident or near miss, there's a lot of buy-in around oral fluids from everyone, because that shows recency of use and it's active drug within 24 to 48 hours. So we want to know if there's reasonable cause, if a person's behavior or whatever you're observing and facts that you've documented are related to a substance. If it's in their system, that's going to be tested through oral fluids, an active drug. Similarly with a post-incident or near miss. If someone's returning to duty post-treatment, that needs to be urine because we're looking for abstinence. And so in that case, we do want to know about metabolites over time. And in conjunction with ongoing aftercare unannounced testing, same thing, it's urines. For pre-employment and pre-site access, all of those reasons, and for random in specific circumstances, it's urines, because we're looking for abstinence over time. The exception to the pre-employment and pre-site access is usually breath for alcohol, but in return to duty and follow-up, it's urine because there's an alcohol metabolite that you can find in urines that you can test for, so up to 5 days post-use. So it's just a fair check on the abstinence. Okay, so what are the key policy elements? Well, we've talked about this already, the fitness for duty. It needs to be written somewhere that you expect people to show up fit for work and to stay that way for their entire shift, free from the use, and notice, or after effects of drugs and alcohol. So it's not just the use at the time, but maybe the residual that could be causing a problem, and then not using or possessing. So that takes us into the next slide around the work rules for recreational use. You don't need to identify recreational use in your work rules, but identify your expectations around use and possession. And again, the time frame from off work to on work, you may or may not want to put that in an operational policy, but you want to have that discussed from an educational perspective. And then what are the consequences? So generally speaking, if you have someone that's using a substance for recreational purposes, then that is a situation where they can be disciplined. If it's an addiction, there's a process of having them get treatment and come back to work, hopefully safely, and be able to be abstinent. Maintain abstinence and be drug-free. Okay, so what do we do around medical use? So cannabis medical use, we integrate it into the work rules. So we have a policy that talks about reporting of any medication-related safety concerns. What do you do with the employee? You need to have a discussion around that. And then what do you do with the information regarding safety concerns? So what's most commonly used in most policies, or the clients that I work with, they find this really effective, is you have a requirement in your work rules around reporting the use of medication-related adverse effects with safety implications. So we're talking about prescription drugs, non-prescription drugs, and medically authorized cannabis. So those are the three categories. Any drug that someone's taking that can affect their safety. And we need to be very clear that you don't need or want to know about any other medications. That's personal, private medical information. And even with this, it's important to stress that you don't want to know the details on the drugs. You just want to know what the safety concerns are, because then as a supervisor, there's a process that you have in place, usually reported to HR or safety. It depends on what the process is within your organization. And then there's the involvement of external healthcare professionals who can access that information and can help make decisions and recommendations to HR. So continuing on with regard to what happens, so the next slide around the duty to accommodate, because this is related to if someone needs a substance or if someone has, sorry, Erin, keep going to the next slide here. So employees need to know what happens when they come forward. So if it's a medication, then you'll have my recommendation is always to have an occupational medicine physician dealing with the GP or the authorizing physician. That way you have doctor to doctor, it expedites things very quickly, and you have the employee has confidentiality of that information that HR doesn't need to know. Because as competent and as multifaceted as HR people are, they're not health professionals and they're not clinicians. I mean, I couldn't even do this. I would strongly recommend, even if a situation that I was involved with, that I would want an occupational medicine physician, because this is what they do every day. So if it's cannabis, they'll verify the medical authorization. They'll go through those guidelines that I referred to earlier. If it's a prescription medication, they'll look at, is the use reasonable? Do we have a safety risk here? And then what happens if we need to accommodate? So the first option always is there an alternative treatment? And usually we're able to meet that goal. If not, are there alternative work roles that the person can occupy while we're trying to get things straightened out? Do we need medical leave or leave? And then does it have to be termination? So obviously we want to start and hopefully fulfill option 1 or 2. And, if nothing else works, then look at 3 and 4. But again, you have physician to physician having these discussions, and it works very quickly and effectively. And then HR has specific guidance from an occupational medicine doctor as to what is the best process to follow, what's the recommendations for this person. Another part that's integral to your policy is your voluntary disclosure and request for assistance. So what do you have in place to encourage employees to self-identify and come forward to request help in dealing with a problem? This is where you get your success. If you create the culture that people understand that it's about health and safety, and you're supporting them to get healthy and safe, you will have voluntary disclosures, and you will have people come back to be the most loyal employees you'll ever have. I could say a whole lot more about that, but as with many of these areas I've talked about today, they could probably be independent webinars that I might be the only one interested in, but there's a lot more information to share with you around this. So my last slide here quickly is the process and the policy, the employer considerations that I strongly recommend is you look at contracting private assessments and consultations. So many of you mentioned consultants already or access to medical professionals. Know who they are. Find out who they are in advance, or encourage HR, whoever you're working with, to do so, because then when these things happen, it's often within a quick period of time and you need to respond quite quickly. So it's helpful to have this set up well in advance. Addiction services provincially are very hard to access. They take a long time. When someone needs treatment, they need it right away. So have the employer, encourage your employer to look at, first of all, having an addiction assessment by an addiction specialist. Again, specific criteria, it's time and cost effective, and it's customized treatment based on what the individual needs. So it works from a whole number of perspectives. I've already talked about the occupational medicine doctor's role and file review, and then the professional overview, and the toxicologist around cannabis kinetics versus impairment. Now, I've gone through that pretty quickly, and we have 5 minutes left for questions, which I'm hoping there are a few. So I will turn it over to you, Erin.
Thank you. So we do have one question come in, and I'm hoping as we read this one and discuss it, there'll be others that come in. So folks, we do have time for questions, so please type them into that chat window. So Reese has asked, I was under the impression that an oral test was not a confirmed test. So if the employee fails an oral, you would still have to send them for a urine test anyway, much like when a driver fails a breath and has to get confirmed alcohol test through blood.
Okay, I'm not sure what the context is there, but many employers are using oral fluid tests, and they've been in place for years, for post-incident reasonable cause testing. Now, you may be referencing the point of collection test because we don't have standardized, approved quick tests for oral fluids. The ones for urines have been in place for many, many years, and they're well vetted and they're quite reliable. So I think that might be what you're referring to. So very important, I mean, it's a good question because it's very important to make sure that you understand the difference between the point of collection test, which is that little device that will give you a yay or nay. I don't say pass or fail because that equates an intelligence test. It's whether or not you had a positive or a negative test. So positive test means that you have substance in your system that is at a certain level. And even with a positive quick test, you need to have lab analysis. So hopefully I've answered that, Reese. So yes, oral fluid testing is being done in many, many workplaces, lab-based analysis. And action has been taken on many of those cases when there's a positive result.
Great. Okay, so we've got a question from Heather. Are employers able to use a quick test in the U.S. to confirm recent use? Is this oral fluid by type?
In the U.S., it depends on what work environment you're in. If you're under the U.S. Department of Transportation and you're federally regulated, so if you're trucking, rail, marine, air, or the nuclear industry, no. The only testing they accept right now is urine-based lab testing or lab-based urine testing. I think I said that backwards. They don't acknowledge any point of collection testing. That doesn't mean employers don't do it, but the action under the U.S. DOT, which encompasses a lot of people in the U.S., is lab-based urine testing only. And actually, though, they've just recently come out as of a week ago with oral fluid guidelines. So that will be in place, hopefully, within a year or two for lab-based analysis.
Heather's clarified that she was talking about non-DOT application, if you can say a bit about that.
So there are certain, I know for sure it's some of the oil and gas companies, yes, they do quick tests all the time. And, but that's an operational decision based on legal advice and what action they take as a result of that. I personally would never recommend anyone take any action until you have a confirmed lab-based analysis, because those labs are very strictly certified and accredited. And a test is, a couple bucks that's manufactured in China, a quick test. So, do what you want with that. It's good if you're in an emergency situation, you're isolated perhaps, but I always recommend erring on the side of caution. If you have a concern, if there was enough evidence in place for reasonable cause and post-incident that you thought substances were involved, you're probably right. And so, better to have someone off for a period of time until you get that lab analysis than the alternative, which is to have them go back to work and have something even more serious happen.
Right, and a question from Bruce. He's asking, are kits for self-testing on urine useful, or should we only use testing labs and point of collection?
Okay, I know some parents that use the kits for self-testing for their kids, and it gives their kids an out when they're asked or they're peer pressured to use their substance. I can't because my dad's going to test me. So again, the standard for workplaces is lab-based testing. Oral fluids for the two scenarios that I've identified because it does show recency of use and an active drug. And urines if you're looking for the others. So I don't recommend a quick test. It's certainly not best practices, but many employers do because it's a lot more cost effective. So again, that I would recommend there be legal advice, that you have a number of people weigh in on the pros and cons around all of that. See, this is so good because this is where most of the questions are, and there's so much misinformation around testing.
Okay. And Cheryl's asked, is post-incident recommended?
Sorry, I didn't catch that. Is
post-incident recommended?
Is post-incident testing?
Yeah.
Oh, yes, absolutely.
And a follow-up from her as well, does a positive post-incident test affect any insurance?
Now that's a very good question, and I've asked that many times, and I've never gotten a straight answer. So that's certainly a very good question to ask your insurance company, because if you're doing the testing, I would hope that that shows that you're being quite vigilant, and that hopefully would affect your premiums. I don't know. Maybe I'm being too naive and realistic and idealistic here. I'm not sure. So post-incident, the qualifier is that, it needs to be a significant incident, not something like, I broke a nail, and I'm being facetious, but it needs to be significant. And that comes to us from the Irving case back in 2012, where they identified very specifically that it needed to be a specific incident. And that's the term that most lawyers will use when they're referencing this in any case.
Great. And Heather had followed up. I think you may have addressed this. Under what circumstances would you choose to use a quick test? And then she said for recent use, of course, with follow-up by lab testing.
Okay, so as an example, Lower Churchill's one of my clients. They've got guys working out the transmission line in the middle of nowhere, and if there's an incident, they can give them a quick test to see whether or not they need to stand them down versus have them go back to work. And I do believe they use them in that circumstance, but they still send it off for lab-based analysis. So that's always the best practice. Some people choose not to. They choose to just go with the result of the quick test. And you know what? If you're ever challenged on that, again, I go back to you're relying on a usually significant operational decision on a test that doesn't, it takes pennies or maybe a few dollars to manufacture, and it comes from China. The reliability of that, I'm not comfortable lying or staying with. That really, the only reliable, definitive information is what you get from a lab where they've done a screen, an immunoassay screen, and a gas chromatography, mass spectrometry quantification of specific drugs and specific levels. You won't get that from a quick test, neither one of those. So a quick test is only presence or absence at a certain level, and rarely are they at the levels that we're testing for at the lab. They're usually above, and they're not testing for all of the drugs either. There's a lot of problems that people are not aware of with quick tests. So I avoid them like the plague, and I recommend that for my clients.
Okay, we're a couple minutes over. There's one more question that just came in, and I'll call it at that. What constitutes a significant incident, and what about following a significant near miss?
Well, that's a moving target. Really, it has to be I tell you what, a lot of my clients will identify things like a fatality, obviously, or a serious injury, medical aid, metal on metal. Some will identify damage over a certain dollar amount, but then you could have significant damage that's low in dollar amount. So those are some of the parameters that some people use. I think, you have to look at the reasonableness of it, and I always recommend that if there's ever any question, you get some legal advice on that. And usually, if you've got a labor lawyer that you can call up and say, okay, listen, this is what happened. Is it reasonable to do in this circumstance? I'm always of the perspective of if you're in doubt and you think it's significant enough, go ahead and test. The reasonable cause requirement is not there for post-incident for sure. I'm biased. Lab-based analysis. Did I say that enough?
Great, thanks, Nadine. Any last comments from you, Nadine, before we wrap up?
I hope I've given you some tools here that you find helpful, maybe give you a few insights that you didn't have before. And there's lots of additional resources that I can provide, Erin. We didn't talk about this beforehand, but I have a handout that lists the number of hard copy books that people can access, and they probably can access them online. And there's a number of good websites as well. That if you want to get more general information for distribution to your employees, that can be helpful.
Great. If you want to send that to me, I will add it to the handouts, and everybody's going to get tomorrow a link to the recording of the webinar and to the handout that we provided today and to the one that Nadine is going to send me to include.
Good. And I thank everyone for your participation. It's obviously something that I'm kind of passionate about, and I could go on for a long time. So I don't know if we want next phase 2 next time, Erin, or not, but hopefully this is starting us off on a good foot.
Great. Thank you so much, Nadine, for being with us today and sharing your time and expertise. Thanks to everybody who's attended today. At the end of the webinar, when you close down GoToWebinar, you'll have a survey pop up. We really encourage you to answer the questions on that quick survey. It helps us to continue to grow this professional development program for you. We have a webinar coming up in December, Rob Halsworth on chemical safety. It's more than WHMIS. That's our last one before Christmas, and we're hard at work developing a series of webinars for next year for you. So thanks again, everybody, and have a safe day.
Thanks, everyone. Be safe.